Mr. Chairman, honorable panel members, ladies and gentlemen, it's an honor to be invited to speak about Amir's Dubai repair on the 4th Mediclinic International Conference and to talk about the short-term outcomes and the feasibility and the safety of the technique. This is an operation that we developed at Mediclinic Parkview Hospital and presented our initial results in the 3rd conference last year. Amir's Dubai repair involves a laparoscopic minimally invasive technique with which we deal with the complex issue of gastroesophageal reflux disease in patients who had previous bariatric operation of laparoscopic sleeve gastrectomy, where part of the stomach is removed to deal with excessive weight, and it promotes weight loss. Before we get to the results of Amir's Dubai repair, I would like to share and discuss some of the data on the issues of the obesity and reflux on a global level. Since the 70s, obesity has increased exponentially, and it has become such a huge problem that at present about 1/3 of the females and about 1/4 of males in UAE have their BMI over 30, which can be classified as overweight or obese. And by the end of this decade, by 2030, about half the population of the world will be in the same category. When talking about obesity, there are various treatments for this, and when all the conservative measures fail, then one has to revert to surgical option, which provides excellent results in terms of weight loss for these patients. The surgeries that are offered to these patients are either a bypass operation, which has been performed over the last 50 years, or a laparoscopic sleeve gastrectomy. And we can see that in the diagrams above and below on the right side, both the operations. There are many other operations which are offered over the years, and the popularity among the operations change. However, these operations have consistently found themselves on the top of the list. Currently, the preference for these operations has changed. And as we can see from this graph, that in 2012, laparoscopic sleeve gastrectomy overtook a bypass operation as the most commonly performed operation for bariatric. However, in 2018, we can see that about 60% of all the operations performed is in the form of laparoscopic sleeve gastrectomy. We will discuss about the gastroesophageal reflux disease, which can occur with obesity, and obesity is one of the leading causative factors of GORD or GERD as we call it. This is so significant that about 15 to 20% of the population all over the world can suffer from this, and its distribution is on very similar pattern in various countries and continents. Lots of treatment strategies have been devised for this, and the disease being so debilitating, surgery for this was considered as early as 1936, and Rudolf Nissen did his first fundoplication. He later described the technique in 1950s, and it's more than 65 years that that technique stands as the gold standard for anti-reflux surgery. More than 11 variations have been described, and these are being used in different situations. Whereas laparoscopic anti-reflux surgery is well established, and so is the bariatric surgery. Both the surgeries are very different in their own rights. So I would like to share some of my thoughts with you about these surgeries. And if we look at the status of the anti-reflux surgery, it's basically a functional surgery in which we try to restore the function of the body without doing any resection, just with a rearrangement of the tissue in the body. Here, I personally believe that it's a super specialty in its own right and not a subspecialty as currently practiced. Anti-reflux surgery is the most complex of the operations of all types of surgery in terms of achieving consistently good results. And that's my personal belief, and you can call this a level 4 evidence here. Another important aspect about the anti-reflux surgery is that there are high expectations of excellent results by the patients, and rightly so, because a person who is suffering from reflux wants to have a normal life afterwards. A normal lifestyle with a good quality is the goal of the surgery in the mind of the surgeon as well as the patient. And the surgeon is expected to get excellent results in a consistent fashion. So the complication rates or the issues should ideally be less than 1 to 2% in experienced hands. Now, when we talk about bariatric surgery, this is a resection surgery in which we resect some part of the body. It's a subspecialty in its own right with dedicated centers and surgeons with their specialist interests. And generally, as opposed to the gastroesophageal reflux disease surgery or the anti-reflux surgery, there is a low expectation of achieving a normal function after the surgery by the patient. The accepted expectation of some of the issues after successful surgery are eating in a different style for the rest of one's life, some abdominal symptoms associated as a side effect of the surgery, and altered bowel patterns. In addition, there is an inherent restricted lifestyle after bariatric surgery, which includes taking medication for lifelong, diet control, following various failures, and of course, lifelong follow-ups after this surgery as well. The goal is to lose weight. The side effects, one has to live with this. And the onus of compromised lifestyle is on the patient. So this is a surgery with low expectation. However, it gives a good quality of life to the patients with weight loss and improved self-esteem. The dilemma of reflux after laparoscopic sleeve gastrectomy is an interesting case scenario because the patients, when offered a choice or as advised by the surgeon, chose laparoscopic sleeve gastrectomy over Roux-en-Y proximal gastric bypass as their initial operation. However, once they develop reflux, currently they are traditionally offered to convert the sleeve gastrectomy into a Roux-en-Y bypass, which was not their first choice. And even if a bypass is done, there is only 60% improvement rate in the reflux, and even the bypass could fail in providing them an effective gastroesophageal reflux disease. Roux-en-Y bypass was not an operation of choice for the patients in the first place, and the operation itself is invasive, involves further resection and anastomosis with a certain leak rate, morbidity, and mortality. So we present the outcomes of our technique to show and discuss about our least invasive procedure to deal with this complex situation of gastroesophageal reflux disease after laparoscopic sleeve gastrectomy. And the main or primary aims of this surgery is that it's a redo surgery and it is done to correct the possible complications from the previous laparoscopic sleeve gastrectomy as a twist, a stricture, or a stenosis, and also to achieve excellent functional results and outcomes from the previous surgery. Now, the complexity of the anti-reflux surgery after bariatric surgery is a super complex area. And in this, one requires an in-depth experience for bariatric surgery, a high-level, high-volume experience of anti-reflux surgery, especially the redo surgery. That's very important. Understanding of the esophageal physiological patterns and complexities is mandatory, and the experience in operating and follow-up over a long period of time in a high-volume center is also essential in order to carry out this sort of operation. The reason for this complexity is several-fold, and that is because it's a functional operation in a redo situation after resection surgery. And the anti-reflux surgery that we are performing, we do not have the benefit of full normal tissue. It's just the residual tissue, whatever is available. And at the same time, we correct any issues which might have occurred as a complication of the first surgery. And one of the things which we achieve in our goals is to maintain the initial benefit of the bariatric operation that the patient had, so that they should continue to lose weight. In Amir's Dubai repair, we described this procedure first time nearly 2 years back, and it follows the principles of all the established rules of anti-reflux surgery. The complication of the initial bariatric surgery are corrected during the same operation, and the lost satiety in the patients is restored, which helps them lose weight after this operation. The initial short-term results of ADR offer the patients excellent outcomes, and it has shown that it cures the reflux. It has also improved the quality of life with 100% patient satisfaction in the short group of patients that we are presenting today. There is a trend towards continued weight loss after ADR. There have been no readmissions, no mortality, and the 5 cases that we are presenting have a follow-up of between 5 to 24 months. For the follow-up, we did a telephone questionnaire with the patients, and 2 independent specialist surgeons conducted the questionnaire. The questionnaire was based on the benefit in reflux before and after ADR, the ability of the patients to lie flat at night, the freedom to eat and drink whatever they wanted to at whatever time, and the improvement in their quality of life, and of course, the overall satisfaction of the patient. We also looked at the weight loss aspects before and after the surgery, the satiety before and after ADR, and the weight loss if they were successful in getting on the path after the weight loss surgery, and the overall satisfaction again after ADR regarding the weight loss. These are the demographics of the patients. The 3 of these patients were female patients, 2 male. 3 of them were near 50, 2 of them were younger, 28 and 34 years of age. And if we see in the 3rd row that they had good weight loss from the initial weight loss of 130 to 100 kilograms, and all of them had lost between 38 to 15 kilograms of weight after their weight loss surgery. If we look at the BMIs, 1 remained at a high BMI of 41, but the others were near to the normal, but their further weight loss had stopped, except the patient number 5, who had pathological weight loss of about 50 kilograms in 6 months due to extreme dysphagia, which was from the stenosis of the gastric tube. The duration of follow-up is between 5 to 24 months, as we can see on the slide. The operative demographics show that the operative time was between 94 minutes to 168 minutes. The patient who had 168-minute surgery had repair of an incisional hernia at the same time. And the patient with 116 minutes, the 5th patient, he had the revision of his stricture in the form of a gastroplasty, which involved a long incision over the stomach and resuturing it back. That added to the time. There were no surgical complications except patient number 4, who had to return to theater twice for removing the sutures because the repair was super competent and he had difficulty in swallowing. Some sutures were removed and his condition improved after that. The hospital stay on an average is 1 to 2 days for these patients. Number 1, patient stayed for 4 days because the patient had an incisional hernia and was an overseas patient. Patient number 4 stayed for 6 days because of return to theaters, otherwise no untoward issues. Patient number 6 had his gastroplasty and was an overseas patient as well and required to stay in the hospital for longer. There were no unplanned returns or readmissions after this surgery. The results are very interesting, that the reflux of these patients before ADR was positive and debilitating for all these patients. However, since ADR, their reflux has all settled and they do not complain of any reflux, except 1 patient who had some psychological and stress issues and had difficulty in managing her diet after surgery, and does report some reflux and occasional use of Gaviscon, but does not have to use PPIs on a regular basis. The satiety before ADR was non-existent in all the patients except the dysphagia that the last patient had, and he had food in his mouth all the time. So basically he had a stricture in the mid-gastric tube and stasis of the food above in the proximal stomach as well as the esophagus. And after surgery, all of them showed positive improvement in their satiety as well, which was meaningful satiety in all these patients, including patient number 5. The weight loss before ADR was good and adequate in all these patients. However, this had come to a standstill and they were not losing some more weight. After surgery, all of them have shown positive improvement in their weight loss, and they have been advised by a dietitian as well, which has helped them to carry on their path and journey for weight loss. If you can see, all of them were able to lie flat at night, and that provided them good comforting sleep. They had a freedom to eat and drink whatever they liked to at whatever time they chose to. They all report a good quality of life and a great deal of improvement, and the overall satisfaction with all these patients is 100%. And these are the patients who have recommended some of their friends and family for this surgery, which is a recommendation in itself of the efficacy of the surgery. In conclusion, we believe that Amir's Dubai repair is a safe and feasible option for treatment of complex reflux issues in patients with previous bariatric surgery like laparoscopic sleeve gastrectomy and gastric bypass in hands of expert surgeons. Amir's Dubai repair is based and compliant with the standard and published principles of anti-reflux surgery, incorporating all the 4 cardinal principles of anti-reflux surgery. I'm thankful to my colleagues for their help in doing this study and preparing the results. Thank you.